Amy, Naomi, and myself are really excited to welcome you to the third session of 2023, which is on simulation best practices and some local examples of what we're doing throughout the country. We're not necessarily going to focus on like really big national models in this because we think people are already pretty familiar with a lot of those models, including VitalTalk. So we're going to kind of focus on more of like the homegrown, smaller initiatives that people might be able to take into their own centers. We're going to have a 3-part session today. We're going to start off with Gina Shannon, who I also there she is. I lost on my screen in the Brady Bunch here. And Gina is the head of our Human Simulation Center at Emory. She's amazing and a wealth of knowledge around simulation best practices. Then we'll have the group from Minnesota. Also, I lost them on my screen, but the group from Minnesota go and they can introduce themselves when they start. And then our little group from Emory. So I think you should be able to share, Gina, if you want to kick us off.
Thank you. It says that I can't. Oh, yes, now I can. Woohoo. Look at that. So good. Thank you. Thanks for your patience as I get it all set up. All right. Get that started. Hi, everyone. I'm so grateful to be here. Thank you. My name is Gina Shannon. I am the director of the Human Simulation Education Center at Emory University, located in the School of Medicine, but we work with lots of other folks. Today, I'm going to chat about applying best practices to palliative care human simulations. When I say human simulation, I mean simulations that involve SPs. They could be standardized participants, simulated patients, SPs for short. But that's sort of what I'm going to chat about today. I don't have any disclosures or conflicts of interest, but I have a little short story about how small the simulation world is. When I got asked to do this, Catherine mentioned that the University of Minnesota was going to be involved, and a person, Ann Wool, who's not on this call, but I think represented, was going to be involved in it. And Ann and I co-chair the abstract submission committee together through ASPE, our association. So it was just lovely to see the world being so small and so intentional. And I just wanted to say that. So today I'm going to chat with you all about the Association of SP Educators, ASPE, Standards of Best Practice. These were published in 2017 and have just been an incredible guide to how we conduct simulation in our center. I'm currently work on a panel on updating these, so we're really excited. We're going to be kind of tweaking them and updating them in the next year or so that more to come. Today, I'm going to talk about 2 of the 5 domains. I wanted to preserve time and really find the 2 that I think are most important for you all to pay attention to and kind of just learn more about. So today I'm going to talk about safe work environment and then training SPs. Under all of the underlying values of these domains are these sort of 5 principles that guide through all of the work that we do and really are the values that lead us. And safety, quality, professionalism, accountability, and collaboration are really intrinsic to all of the work that we do in human simulation. So today I'm going to talk about domain 1, safe work environment. Personally, I find this one to be one of the most important parts of the best practices, but I'm going to really focus on the 3 principles that are under the safe work environment, and that's practices, confidentiality, and respect. Starting with practices starts with when you start to design your simulations. My center works and partners and collaborates with all kinds of folks and departments when developing human simulations. And things that we want to think about when we are designing those human simulations are safe practices. What are we doing to put up safe practices, not only for the SPs, but also for our learners and for the faculty who are working with us? And one part of that is designing time, allowing for time to pre-brief and prep folks to prepare for the simulation. Also timing, allowing for breaks, both mental and physical breaks, especially when we're talking about palliative care sessions. And then to provide opportunities for debriefing. That's really the most important kind of parts of simulation, both debriefing the simulation and also globally, we do a de-rolling and sort of a breakdown and debrief with our SPs to get them out of the simulation. The other part of it is casting of SPs. We are very conscious of providing enough information for our SPs to make an informed decision on whether the case is a good case for them to portray. So we try to provide them as much of the case details, the design implementations of the sims, and just make sure that when we're casting them, that they know everything about what is going to happen with this simulation so that they can decide if this is a good fit for them. With that in mind, we also have a lot of guidelines and strategies on how to, how far is too far, and where are the limits and guides within this simulation to make sure that the SPs feel empowered to stop, to not have to go further than they feel comfortable, and also strategies on how to, leave. This goes for the learners too. When can they say stop? I need to recalibrate. And that's really important when we think about how we're designing safe work environments in simulation. The second being protection of privacy. This is, everything that happens in our Sim Center remains in our Sim Center. Nothing is talked about beyond that. It's kind of like Vegas rules, what stays in Vegas, or what's done in Vegas stays in Vegas. That's how we operate. We ask our SPs to not give their real names because we want to make sure that everyone is feeling protected in private. And then finally, respect. And a way that we really want to make sure that we're providing respect to our SPs, our learners, our faculty, is providing them adequate information for them to make informed decisions. So that means that having a clear training, case development, making sure the learners have a pre-brief so they know what to expect and when to expect it, and also faculty development, having the faculty understand what is it that we're trying to achieve with this simulation. This is all done in collaboration and partnership with our faculty. And so the second domain that I want to kind of discuss is domain 3, and that's training the SPs. And under that domain, there are 5 principles that we lead by, and that's preparation, role portrayal, feedback and debrief, assessment, instrument training, and reflection on our training practices. So in preparation, it's really important for us to be able to prepare in a way that's, gives us all enough time to be really thoughtful about what we decide to do in the human simulation. We need to have the cases and sort of the design pretty far in advance so that we're really clear about what we want to do. And then also giving us time to be able to read through the cases so that we can find any places that maybe there's gaps of knowledge, or maybe we need to provide a little bit more context for the SPs, and then prepare so that we can have time to prepare a training agenda. In our center, everything we do is there's a prepared training agenda that we send to all of our SPs so that they know exactly what the training is going to look like and what our expectations are of the training. The second principle is role portrayal, and I just want to point out that it is not role performance. it is really important to recognize that SPs are not performers. There is not an audience they're performing for. This is a portrayal. They're portraying likely something that is a case that has been developed based on something that the healthcare providers you all have seen and witnessed. And so by honoring that, we recognize this is not a performance. This is not an opportunity for them to, win a Tony or an Oscar. This is an opportunity for them to engage and portray a case that is educationally, led. And so that's really important for us to distinguish that and understand the difference and really relay that to our SPs. Another part of it is that we want to make sure that we are very clear about the key learning objectives and outcomes, the responsibilities that SPs play in this role portrayal and simulation, and then the context. I think even more so in palliative care cases, they're usually kind of a slice of what has happened, a slice of life. And so we really want to be able to provide the SPs with the context and understanding within the case of what has happened prior to this conversation. It's important that they also understand what role the SP plays in the simulation. It goes back to understanding guidelines, understanding the parameters. And we want to make sure that they have all of these things so that they can portray the case in an authentic way. One caveat when I say authentic, I really don't want anybody to go method on this. I don't want them to embody this character so much that it's harmful to their psychological safety. And so we're really careful to say, hey, we're not going to ask you to cry on cue. That's not something that we're going to ask you to do. We're going to ask you to listen and to simulate what you would think this person would respond, how they would respond. And it's all within parameters. It's very clear. However, I want to recognize these conversations are messy. And that's okay. And we want to provide space, a safe space for the learners to sit in that discomfort. And to really be able to have those conversations and sort of fumbling potentially or really doing well in a safe space so that when we debrief, we have some things for them to talk about and some tools to put in their tool belt when they go out to clinic. So it's really important that we're clear that it's authentic to a limit. We are asking them to simulate, not standardize. And standardization typically comes with, across the board, everyone's doing the same thing. We're testing. We want it to be authentic, that each learner is going to approach this in a different way and that the SP is responding in an authentic way. And then finally, during the case trainings, we want to make sure that the SPs have a readiness and understanding. And so that's usually a check-in with case questions and potentially some role play during the training so that they have the opportunity to embody the character and get a sense of what is going to be happening in the simulation. So the third one is also feedback. I added debriefing because that's really more of what we do in our center. Feedback being, the distinction being feedback is something that is observing, a behavior and then directly relating to the impact that behavior has had, where debriefing is allowing for a group to have a conversation and it's really learner centered. So it's focused on the learner and how they felt, also what they observed and how, things that the challenges they were met with or things that they think they did really well and providing them opportunity to walk through and discuss those. Our SPs are trained to make sure that they are focusing on the observation, so observing the behavior and inquiring more about that behavior rather than assuming or inferring about something. So if a learner crosses their arms, we ask the SPs if that had impact on them to really ask the learner, hey, I noticed you crossed your arms when you delivered this particular challenging piece of news with me. Can you tell me, what was going on? What were you thinking at that time? Versus I assume that you were, frustrated with my response. You crossed your arms. We're hoping that this can reduce any sort of bias. We all know we have bias, but I think this is a better way of looking and approaching this work. And it's always about seeking curiosity for better understanding. We want to model that behavior for our learners and for our SPs. In palliative care with the PEDS folks that we work with, the SPs don't complete an assessment instrument. However, in other simulations they do. So this would be a part of the training, is making sure they understand the purpose and why they are using these assessment tools. And then always reflection. It's really valuable to always take a moment and reflect, like, how did the training go? What were some gaps of knowledge maybe that you feel like your SPs had and that you want to return to? What's some further information you want to ask the faculty about the case and things like that? So, you know, it's kind of an ongoing joke. I'm always asking the staff to reflect and think about what we're doing, because we are working with humans. We want to be really intentional about what we're doing and how we're doing it. So just to recap, these are the ASPE's best practices, standards of best practices. Really, if you're not familiar with them, I really encourage you to take a look at this document. It's been a real great gift to the field and has a lot of really valuable information on how you construct and design and implement your human simulations. Thank you so much for your time. I really appreciate you all inviting me to be here. And please reach out if you have any questions or thoughts or comments. I'm really open to hearing anything that you all have. Thank you so much.
Awesome. So if you guys have any questions for Gina, pop them in the chat. She is like a complete simulation expert in SPs, debriefing, high fidelity versus low fidelity. Any questions that you might have, we'll pop them in the chat and she can address them as we go along, or we can get to them at the end. And we'll move on to the group from Minnesota. I know we have Stacy and Johanny here, so I'll let them introduce themselves and their work there at Minnesota.
Thank you. Are you guys seeing our slides?
Yes.
Great. Anne was not able to be here, but is part of our process. And as Gina mentioned, is one of her close colleagues in simulation. So they would share some of the same stuff, but I will let Stacy take it away.
Oh, okay. Hi, everybody. Really great to see you, even on Zoom here. And I'm going to give a little introduction here to our presentation. We have been working on this project now for, oh, is it not driving? We don't have any disclosures, so there you go. I think we started this as an offshoot from another simulation project, and I think we've been at this now about 5 or 6 years total. In this particular iteration, we've now run it 3 times, I believe, Joanna. And our goal was to improve end-of-life care for pediatric families and patients and their families, and also to improve trainee competence in providing end-of-life care for their pediatric patients. So see our vision point number 1. And to enhance the well-being through education that trainees and practicing clinicians need in order to work through traumatic clinical situations. We recognize that pediatric palliative care is a team sport, and that it's also a very stressful event, even for people who are quite practiced on that. Let's see. Okay, next. We did publish information about this if you want to go and learn more about it. We've had quite a robust team of developers, some of whom are listed in this article, and there are others. And we just want to acknowledge all those folks who've contributed over the years. We also were very intentional about the way we structured the case. and the way that we presented the information to the Sim Center and our collaboration with them. And perhaps the most novel element in this simulation was we had two bereaved parents who were advisors in the planning and that also participated as faculty in the simulation process itself. And I think, Joanna, you're up.
Yeah. So this project really builds on our previous project, and you'll see Naomi, one of the leaders of this group, when she was at University of Minnesota, was a leader of our workshop for fellows. But we are not going to emphasize that today. We're going to focus on our interprofessional one and kind of show how we went through Kern's 6 steps of curriculum development, and we're still in the evaluation phase, and use that as kind of landmarks of how we did this. So the first step, problem identification, Stacy already talked about it a little bit, but unlike CPR, where there's, a cookbook of how to do it and providers get certified, there's not something like that for pediatric end-of-life care. And we see it as similar in that it's fairly low frequency among kind of all of pediatric care, maybe not among this audience necessarily, though is very high intensity as Stacy started to talk about. And so what's missing is some primary pediatric palliative care knowledge and skills for all people working with pediatric patients and their families, because for families who are going through this situation, I think Naomi is one of the people who coined that we just have the one chance to get it right for each individual patient and family. So that's where we saw the problem. And as we looked more at a targeted needs assessment, looked through a number of curricula, you'll see familiar names here, and really in doing our fellows workshop, which there's benefits to doing it with just fellows, saw the opportunity to do better education across all team members who are involved in this care. And this is just a number of the team members that you know well, and there are many more, of course. So we put together an advisory board made up of physicians, social workers, nurse practitioners, spiritual health, bereaved parents, and a simulation educator, Ann Wool, and worked on this together. I'm not going to go a lot into bereaved parents. Happy to take more questions about that. That has been something very important to us. We have 2 parents, Danelle and Kelly, and there is a lot of research that's been done about the benefits. There's also some important considerations to make sure their work with the group is beneficial and not harmful of their ongoing grief process, and is helpful to the educational group too. So in our program, we've put a lot of importance on how they share their stories with any new group they are meeting with, and that they have been involved from the inception of the project to delivery. So they have helped in developing it. They are co-learners while facilitating, as are all of us as facilitators. They are paid for their work as professionals. It's not something that they volunteer for. And really, they are there in educational roles with their personal experience helping in the educational role, but we never put them in the situation to role play a parent. We have our standardized patient program with that follows all of what Gina has said in best practices. So for that reason, and for the safety of the parents themselves, So it's separate, it's considered separate from their own grief work and ongoing grieving process, though it's still part of kind of the legacy to their baby or their child who has died. And so these are our two parents, Danelle and Kelly, and their Levi is one of Danelle's sons, and Charlotte or Charlie is one of Kelly's daughters. How we came up with the goals and objectives for this is we really saw that the pediatric palliative care, the EPEC program has set forward lots of modules, and we use that as a starting point. And again, honed in on end of life care, and then use the interprofessional competencies as guideposts as well. And then I'll turn it over to Stacy again.
Thanks. Yeah, just to dig in a little bit to this idea of interprofessional collaboration being a competency in particular. And if you think about it, in many of our, well, I think all of our professional training, it's very uni-professional, and it's in the practicum or internship side of things that we would get some exposure to collaborative practice, but as we all know, that can be very piecemeal in terms of representing best practices. So it's very helpful to actually identify and name these components. So as you can see in this nice little model here, interprofessional teamwork and team-based practice, communication, understanding roles and responsibilities, and having shared values and ethics that guide interprofessional practice are all essential elements of this. And this is part of the building of safety, psychological safety for practitioners, as well as families and patients. Because if you think about it, when the professionals are squabbling, of course, that's not a good thing for patients and family-centered care at all. So sorry, my dog seems to be excited here. So again, just to kind of reiterate the four core values that we talk about are values and ethics, understanding roles and responsibilities, which we've really built into our simulation very conscientiously and given our learners an exercise as part of the preparation, the kind of team formation component, where they can talk together about what they see their role as and what they feel responsible for on the team, and how they can understand each other better, even in a very brief period of time. I think we did this a couple times before we really added or beefed up this component, and our learners have given us feedback that it's been really helpful. And even just, 10 or 15 minutes for our group of learners to spend some time talking about that has helped them understand each other better and feel better prepared to go into the simulation. And for practitioners, I would just invite everyone to think about how often they've had that conversation with the people that they're going in to have these conversations with as well. I should mention too that we were really aiming this at primary palliative care level. Our case had 3 different phases or stages. And so this idea of formulating the team, sensibility in our learners was important. They're going to carry that through all 3 scenarios, but I think also in practice, they learned that it doesn't take very long to actually get a better feeling for your team and how you're going to work together. And so I think that was an important takeaway. Anything else you want to say about the team collaboration piece? Johanna, you want to chime in here? Or?
No, I think that says it all. And so kind of from building on that, we have a number of objectives. So we're not going to go through them, but just to share that we have made objectives for the workshop. And now to talk a little bit more about our educational strategy that Stacy started to mention. We deliver this with a deliberate practice framework, and really through experience in the simulation environment and ongoing practice and coaching in that, we hope that that people improve their clinical competence. To say, so as Stacy started to say, we start off with a pre-brief and do some just-in-time teaching, and then we do a team building exercise, and that's when the learners meet with facilitators, the patient and family on paper. And then they go into 3 epics, we call them, of time with standardized patient family members, the patient's mother and grandparent. In the first section, this is a pediatric oncology patient who has a recurrence of his diagnosis and is seen in the primary care clinic, and the team is kind of helping the family through figuring out if the cancer is back, the communication surrounding that. The second part takes place on the hospital ward, where the family has gotten the news that the cancer is incurable and wants to go home. And I will say that with the level of learners, we're not having them lead a care conference giving this news that the cancer is incurable, but they are instead the trainee team they were at the conference, but then the family has more questions and calls them back to the bedside in the evening, which we think is realistic to what they could actually be asked to have a conversation about in the clinical learning environment. And that's true for each of the 3 epics. In the third, the boy Josh is in an active dying process in the ICU, and it's about talking more about what does it look like to do an extubation at end of life, symptom management, again in their role as trainees, not trying to suddenly be the attending intensivist or the social worker in charge, but as trainees. In between each of these, they get feedback with the standardized family members and interprofessional facilitators in each of their small teams, and then we do a large group debrief at the end. This is a representative picture of the standardized family members, a team of 3 learners there, and then interprofessional facilitators after one of the epics doing feedback together. We have facilitators fill out a checklist about how it has gone, and we do that at each of the 3 time points and plan to look at how their competence improves over time. So implementation, we've now done this with 43 trainees among the groups listed there. A huge part of implementation is having the money to pay the simulation center, and so funding has been required, and we're fortunate to have a foundation source for some of the funding, but then for this project with the interprofessional project, we also have a grant through our institution for this expansion project. We have started to evaluate how this is going. We presented it at Pediatric Academic Societies in the last month, and of course this is too small to read everything. It's kind of an early look at self-assessment. Most participants found that they either stayed the same or improved in the areas they agreed with that we were trying to target, and they felt the workshop was effective. That we hope to look at higher level outcomes as well, and do some qualitative analysis. But that is a quick summary of we do have a website if you are interested in finding out more. And yeah, hope you learned something from our quick summary. And like any of these big projects, it has taken a huge team among faculty. We have some trainees, we have a coordinator, and then the simulation center, of course. Again, Anne was sorry to not be able to make it.
I would just add that we certainly designed this for fellows and students, but we've also had some participants who are early career folks, and they found it very helpful as well. And I think we should keep that in mind too when we think about onboarding new members of our teams, that these kinds of exercises could be really helpful in that, kind of ramping up of skills too. Thank you.
So I just want to bring up Mike's question in the chat. Stacy, I know you answered it, but Mike asked, or you kind of partially answered it. So Mike asked if the learners focus specifically on their own role, or if they have the opportunity to explore the role of another healthcare professional. And I think he was asking kind of for both, or Mike, you can speak for yourself, but he was kind of asking for both kind of the exercise at the beginning, but also for the workshop in general, because at St. Jude, they've had experience actually role playing a different role than their regular role. And I guess Mike can speak a little bit more about that.
Yeah,
Really
yeah.
interesting.
In previous training opportunities, both here as well as in med school, we had as an interprofessional event where we had a role play, we had an experience, we had a walkthrough, but you weren't allowed to play the role of what you were training for, right? So for example, as a physician, you would play the role of a psychologist. The psychologist would play the role of a physician, and the nurse would play the role of a psychologist, or what have you. And so the idea was to think about the other roles and responsibilities of the other members of the interprofessional team and see how that worked, and really trying to build that understanding of the fact that we're all in it together, and how those different roles and responsibilities were there. And so that was part of the question that I had, was with regards to the opportunities to kind of learn in that space, and not necessarily say, okay, this is my role and this is what I'm going to learn, but how do you learn what the roles and responsibilities are of the other members of the team to have a better comprehension of the type of experience that they have and the roles that they have.
Yeah, I can say a little bit more about that. That's really interesting. I would wonder how people felt being put into something that they don't have training for. But yeah, to build on what Stacy shared, I think we are asking people to do work that would be within their role. Like I said, we're saying like they're not leading a care conference, they're answering questions after the care conference. That being said, we are also encouraging them to like see where the role can be flexible and how they reach out to another. And I can think of one of our large group debriefings that a social worker who has been in her current role not very long talked about, wow, this was really interesting. I found myself saying things that I wouldn't say. I feel like they're outside of my role in real life, but it actually was really effective coming from me. And so we are trying to encourage people to, have that flexibility.
And I think in the interest of everyone getting along, we often focus on the areas of overlap and commonality. And what's harder is to talk about really what I feel absolutely responsible for. And I need people to respect that about my role. It's kind of harder to talk about actually. And, I think that it's obvious maybe for physicians and prescribers in a way that's different for some of the other roles around some of the things like family counseling and emotional support and spiritual support and things like that. And so I think this exercise, and I've done some of those kinds of things where you described, Michael, and other interprofessional education activities. But I think what I like about this particular exercise is that it's kind of both and, right? Like we share with people what our training and preparation and scope of practice is and what we feel responsible for. And then we can also negotiate and talk about it. Where's the overlap and all that kind of stuff. So I think there are both excellent sides of the coin. Hopefully we can explore all those.
This is such a great discussion. Thank you so much. And then we need to move on to the next presentation.
All right, so I'm going to introduce the two of us and then let Megan take it over. So Megan Trzaski and I are at Emory University in Children's Healthcare of Atlanta. And I'm a palliative care faculty and peds oncology faculty there. And Megan is the founding nurse practitioner on the pediatric palliative care team at Children's, and had started this work with simulation-based palliative care education. And then I joined her when I came to Children's in 2016. So we don't have any conflicts of interest to disclose. So I will let her take it from there.
Hello. So as Catherine said, I helped start the program here in 2011, but at Emory, they had been doing simulation-based communication training since about 2008 with the critical care fellows. So this really evolved out of a need that the critical care department felt they had. So a lot of our funding comes from the fellowship specific departments. It says my internet connection is unstable. So if I'm splotchy, I'm sorry. So we started with the PICU Fellows in 2008. They brought me on board in 2011 to provide insight around palliative care specific Breaking Bad News. And then when Catherine joined us around 16, she and I became the co-facilitators for this entire program and really took ownership of it. And we since then got the Hematology Oncology Fellows incorporated in 2017. And then in 2022, we did our inaugural NICU Fellowship training. And over the course of the last 10 to 12 years, we have been able to invite different participants from like pulmonary or ECMO fellows or other practitioners. So we try to bring all of the new nurse practitioners, PAs in the critical care areas to run through these sessions with us. And when we're talking about the training sessions for us, they're about half-day training sessions that occur twice per fellowship year for all 3 years of the fellowship. So we're running about 6 sessions per year on our team. So we've done this, 50 to 60 times at this point. If I could make the bubbles on this slide a little bit different sized, I would say that the majority of the work that we do is in the pre-session coordination for each individual simulation that we run. And to honor what Gina talked about, the reason we put so much effort into that is to ensure the psychological safety of all of the participants, from the SPs to the faculty to the fellow, to make it as realistic as possible, but also as safe as possible to focus on the needs that they have. So it requires a lot of preparation. We write 3 prompts for each session specific to the discipline that the fellow is coming from. So neonatology, we talk about like preterm births with multiple congenital anomalies. We talk about kids that have advanced stage disease from cancer with progression or relapse. And then critical care, we do a lot of Breaking Bad News in this setting of an acute trauma. Our deadlines really begin about 4 to 6 weeks before each session, when we have to provide the simulation center with information about what the case that is we're running, the evaluations that we're asking the faculty to complete because they have to upload it into their computer system, how many fellows are participating, which informs how many SPs we need for each session. We identify faculty from the discipline as well as palliative care faculty. The discipline faculty are usually physicians who either are experts in this themselves, or sometimes we try to just invite people that maybe need a little bit of training on their own, but we boost their ego and say, hey, you should come and do this with us. And then they're like, oh, I took something away from this, even though I've been practicing for 30 years. And our palliative care faculty, we use our nurse practitioners, social workers, and physicians to really emphasize the IDT component of the work that we do, and the component of having difficult conversations. So in the fellow prompts, we go through things with their learning objectives, the relevant history, medical details that they would need going into the room to feel comfortable getting the conversation going. And then again, a prompt to begin that discussion. The SP prompts really include background, like somebody talked about, to establish who is this patient and parent that we're talking about? What do they need to assume this role in this setting? And what are some ways that we can give them question statements and prompts so that they can really have this improvisation within each encounter, because every room is going to run slightly differently. We give them information about their family, their religion, whether they work or don't work. And like I said, we select the faculty, we do the evaluation surveys, and we send a lot of stuff over there, but it's so much work going into it so that the day of runs smoothly. You can advance, Catherine. This next slide, and I'm rushing through these, I apologize, guys. So this is kind of an example of what are some of the components that go into each of the cases that we write. So the themes that we try to address over the course of the fellowship. So we try to make sure if you're coming into the 6 times over the course of your training that you're not getting the same case or the same objectives each time that you come into the session. So the first scene that is run on each day is really usually the Breaking Bad news one. And then the next one builds on the complexity of let's start exploring the goals of care or withdrawal or disclosure of prognosis. And then the third scene is either around end of life, decisions around hospice, or maybe the child has actually already died and you're going in to have that conversation about what to do. And then the objectives are there. And then that's a little abbreviated case scenario of one that we run for both PICU and oncology because it's an oncology patient. And the day of, if all of the stuff leading up to the day of is done well, then hopefully the session runs smoothly and it is a well-oiled machine. So all of the prep work is super, super important, but being on time and being coordinated because everything is, I mean, truly to the minute on the day of. Catherine will go through some of the slides of what it actually looks like. We give all of the fellows an introduction to the sessions. If they've never been there before, we encourage them to suspend disbelief. I'm notorious for killing off the other parent so that there's not a lot of questions about who that parent is, and then also to add to some of the complexity of the grief experience of that parent. We talk about the Vegas rules as Gina discussed, and then we run down how the scenes are, how it will play out for the day. And then we do a wrap up at the end, which I think Catherine's going to talk about.
So this is sort of like what our day of layout looks like. We basically have the fellows blocked for a half day. We take about 20 minutes in the beginning of the day to kind of go over the rules for the day and orient people to the sim lab. They have already completed self-evaluations and surveys via like REDCap before they come to the sim lab. So that's already done. And then we basically run through 3 different scenes in one child's case. And for each scene, we take 15 minutes to do the scene and then 30 minutes to do the debrief. We have 1 fellow that participates and kind of is in like the quote unquote hot seat. And then we have 2 fellows who are in the room observing and really taking note of the language that's used and body language and all of the verbal and nonverbals. Behind the scenes in each room, we have 1 discipline specific, like PICU, NICU, oncology faculty watching and 1 palliative care faculty watching. So 2 faculty, 3 fellows, and a sim lab specialist per room. The faculty are watching this session via like kind of like a mission control room with lots of computers and completing evaluations of the fellows. The ones that we particularly use is called the Modified Kalamazoo Communication Assessment Tool, but there are multiple that you can choose from. So we basically do that 3 times, just rinse and repeat, and then end the day with a wrap up and a take home point from each fellow. Our sort of core principles are, I think, I really have to credit Lou Halamic from Stanford and CAPE. He trained me in this in simulation and runs a pretty tight ship out there around neonatal resuscitation and NRP. And so our core principles really stem a lot from that and what's in the literature, which is to make the encounter as realistic as possible. If the fellow would be scared to have this encounter in real life, I want them to kind of be scared in the sim lab. Not like freaked out scared, but like your heart's racing, you feel a little bit sweaty, like if they would cry in real life and they cry in the sim lab, that tells us like how realistic it makes them feel. And they frequently comment on this, that our SPs do an amazing job to make it feel very realistic. We also work really hard to let the fellows drive the cases. We ask them every year, what are the cases that you have found difficult? What would you want to practice here? We don't allow a timeout in the middle of a session because that does not happen in real life. So we go from start to finish. And if they feel like they screw up, they can just sort of work through it in the moment. We totally value the IDT. This is palliative care. There's no question about that. We, in this setting, do not give these fellows a buddy because these are oncology, neonatology, and PICU fellows. They are frequently having these conversations in the middle of the night or by themselves. So we really want them to go in and be able to lead and go through these conversations by themselves if necessary, and not bail out when they get to the psychosocial information or turn it over to somebody else. So remember, this is to practice and learn. This is not, they do have these people in real life in the hospital and get a lot of practice working with them. So we make the environment as similar to the hospital as possible. We want to really facilitate a positive learning environment. Fellows tend to beat themselves up in these scenarios. They very rarely will comment on all the things they didn't do well rather than the things they did do well. So we really try to engage them in positive comments and help them see what they did do well. We kind of take the approach of like, you're all coming in here as really high level learners. Let us help you get even better. And as Gina mentioned at the beginning, we debrief. This is not feedback. That's why we allow 2 to 3 times the amount of time for debrief as we do for the scene. The debrief and the debrief is where learning happens in the sim lab. So the goal is to really do open-ended questions in like sort of a 3-to-1 ratio of open-ended questions to statements by the facilitator, and to facilitate self-reflective learning. So 3 times the amount of statements should be said by the trainee compared to the debriefer. We use silence to facilitate conversation, just like we do in palliative care. And importantly, in our sim lab, we do the scene and then we go all into the debrief, and we use immediate video replay to focus on the learning goals. So immediately after the session is over, the fellows see themselves on video. We kind of focus on the parts of breaking bad news or the goals of care discussion or those types of things, but we use video replay and they're able to watch that in the moment during their debrief. We ask them what just happened. Give us your initial reactions, your initial feelings around the case. What did you do well? Tell us where you felt like you struggled or you felt stuck, because then we can find that place in the video if we need to and go to that. We ask them, if you did something really well, what can be done to facilitate that positive interaction? What made the communication effective? Or if there was something that was challenging or a negative part, like if they, for instance, used the words withdraw care or certain things that we didn't love, then we ask them kind of what can be done to prevent that type of negative interaction or what made the communication less effective. So we also kind of think about the debriefing flow. So when you're in the debriefing room, there's the 3 fellows, the 2 faculty, and the SP, or the simulated participant or simulated parent in this session. Luckily, all words start with P, patient, participant, and parent, but in this case, they're the simulated parent. We ask the participant for a quick summary. We let them start. Then we ask their co-fellows to reflect on the scenario and let them jump in, because your co-fellows are universally very positive about what you did in the sim lab. They very rarely say negative things about you. And then we ask for the SP to participate in how they felt as a parent. And then we kind of work through the case longitudinally. So I just put this in just to really, so that you guys could have it, and that when we put this online on YouTube, that we have this in there. The importance of debriefing in clinical simulation is so paramount. The experience of the education itself is directly correlated to the debriefing. And so just really remember, like when you're focusing on this, there's so much attention to the case itself and the minutes that the fellow is in the sim lab, but you really also need to train the faculty that are doing this on debriefing techniques, and really how to be the best debriefers that they can. This is sort of what it looks like in our sim lab. There's the SP who is in the purple shirt here. There is a fellow who is in the green scrubs. And then you can kind of see, like with the feet down below, there are 2 fellows sitting behind the fellow who's in the hot seat, and they listen in and participate in that. And so they're kind of listening, actively participating by listening actively, writing. Sometimes they will write down things if they need to remember, but we ask them to sort of really take note and remember what their co-fellow did to make it a good scene or a good encounter. And then lastly, when you wrap up, you basically should, provide gratitude and thanks. This is a lot of time for people. It's an intense effort, but we basically wrap up with the SPs. The SimLab staff do that. We subsequently collect data from the faculty and the fellows. We send out a faculty thank you, and then we basically, start scheduling the next sessions. So hopefully that's like a pretty high level overview of what we're doing in a very complex way. Like I said in the chat, we're happy to share things with you. I'll pop my email in the chat as well. And lots of thanks to our SimLab, the Emory Center for Experiential Learning, or Excel, Gina, Deb, Elisa, and Sherry there, who really make this whole session run. Without them, this would not be possible. Our palliative care team, Kieran Habar is one of our PICU docs who started this, Nick DeGrood, who helps me with my data around this. We've had over 80 fellows participate, and we have data on over 80 fellows. So we're hoping to publish all of that soon. Again, with funding, we have some funding from Fraser Parker Foundation, and then our fellowship groups actually felt this was so important that they now pick up the cost. And my own personal mentor and who taught me how to do this, Lou Halamick and Cape. And if you're interested in debriefing education, they have an online debriefing education session that you can join and learn from. So I will leave it there. I'm just peeking at the chat.
There's no additional questions. There was one question that
answering all the
Stacy
questions.
asked. Yeah, Megan was answering the
As you were
questions in the
talking.
chat already.
Perfect. I saw lots of chat bubbles going. Yes. Cost is definitely an issue in many places. The best thing we've done is like really work with the fellowships. If you have a school of medicine, or you have somewhere where you can get the SimLab time covered, then our main costs really involve actor time and like food for the day of the session. If you are in a place where you have to pay for your SimLab time, that can run you, $100, $200+ an hour. So that can be cost prohibitive. So really trying to find the place that allows you to do this in the most cost effective way. Awesome. Well, I was going to share a little video with you guys of what it looked like, but I don't think we have time, and I want to make sure we end close to on time. But if you have questions, certainly feel free to reach out. We're happy. This is like not proprietary in any way. Megan and I tweak the sessions every few years to make it updated. And we had to tweak a lot for the pandemic when we went virtual and now back to in person. So we're happy to share. And I imagine lots of people on here are as well. If you have sessions that you're running and you have questions about, we're also happy to help in whatever way that we can. And I'm sure same for the group at Minnesota, who has a lot of experience in this. We've started, as you can see, we've taken different approaches. There are many different ways, as in palliative care, there are many different ways to skin a cat. But I think all of us certainly have the goal of improving our trainees and our interprofessional teams throughout the hospital. So awesome. It was really great to have you guys with us today. And we will see you in July. Now that feels like really crazy to say. The next session will be in July. And Naomi, I forget, do you want to tell them what July is?
So July, we will be featuring 2 works in progress, and we actually already have those slots filled. But if there's anyone in the future who's interested in presenting any works in progress, send it along to me, and we'll figure out how to kind of slot you in, because that's really one of those things that NIPSI is for as well. So looking forward to seeing many of you, as many as possible. Bring your friends in July, where we'll hear about works in progress and hopefully be able to give those teams some helpful feedback on their projects.
Thanks so much, everyone.
Bye,
Thanks
guys.
for having us.